Hi, and welcome to the August 21st, 2013 Plastic Surgery Journal Club, coming to you from St Vincent's Hospital in Sydney. I'm Damien Marici. This is Dr. Francesca Ranard, who's one of the accredited plastic surgery registrars. We did the usual 4 papers today. The first paper we looked at was from a very recent PRS, and it's called the Descending Branch of the Perforating Branch of the Peroneal Artery Perforator-Based Island Flap for reconstruction of the lateral malleolus with minimal invasion. This is a Japanese paper. And Francesca, what was the general gist of this paper?
So the general gist really is regarding reconstruction defects over the lateral malleolus. It's a very challenging area, and it's giving a method for reconstruction of that area. And
so can you outline what was the basic anatomy of this newly described flap?
So it's a bit of a tongue twister, but basically there's the peroneal artery perforator, and that divides into 2 branches, the descending branch and also the superficial cutaneous branch. There's been previous flaps that have been designed on the superficial cutaneous branch, but this is actually designed on the descending branch, which is a lot closer to the the lateral malleolus.
And it's a specific perforator from that descending branch.
That's right.
Which they found to be only about 40 millimetres from the lateral malleolus in their studies, which is obviously a lot closer than the superficial or the superior branch. So the perforator from the descending flap. Yes.
Yeah.
Good. And what about their clinical applications of it?
So it was a 2-part study. First of all, it was based on cadavers to determine the anatomy, and then they designed a island flap based on their results from the cadaver studies. So basically in 5 patients, they carried out the flap with quite a large skin island, and basically based the centre of that flap over the perforator, and that was the pivot point. Designed the flap in line with the artery, and then basically propelled the flap, and they found that all of the flaps were successful. None of them were closed.
Sometimes they were able to close the secondary defect primarily, and sometimes they needed the skin graft. But it was a very interesting flap, a newly described flap for a challenging part of the body where you don't want to be doing a free flap for a very small defect. And I thought generally it was well received. Good. Okay, the second paper which we did was the comparison of harvesting and processing techniques for fat grafting and adipose stem cell isolation. And this was from Pittsburgh in the United States, and is also from a very recent PRS. So the gist of this paper was comparing, there were 2 parts of it. The first part was comparing different filtration pore sizes, wasn't it? For a new closed liposuction production of fat grafting material. And they were looking at different pore sizes. The second size was looking at different ways of preparing fat for fat grafting, and they were comparing the traditional Coleman fat grafting technique with the centrifugation and the like. They were comparing that with cotton gauze rolling using Telfer, and finally comparing it with the filter technique, which one of the authors was involved in a company that produced the technique.
And
so,
also,
what was it? Yeah.
They also compared just the suction-assisted lipo aspiration as versus the ultrasound technique.
And what did they find?
They found that the technique of harvesting the fat, so either lipoaspiration or ultrasound, didn't really make a difference. They were both very similar in their in how much fat survived, and that the pore size also in the filters didn't make a difference either. The phase 2 part of the trial, so determining which was the best method of processing the fats, they actually determined that cotton gauze rolling was by far the best, followed by filtration, and then finally centrifuging.
So, what do people think about this paper?
Overall, I think people were very interested, and it goes in line with what actually the consultants are currently doing. Most people have a similar method, so similar to cotton rolling when they're preparing the fat.
Yeah. Well, obviously there were some issues in the sense that two of the authors were involved with medical devices directly involved in the study, but given that their particular medical devices weren't being promoted as actually the best and most reliable method for fat grafting, it in many ways gives the paper more weight in that the cotton gauze group actually had the highest percentage of fat graft survival. But they suggested that cotton gauze rolling was probably not practical for very large volume fat transfers that you may require in either reconstructive or breast augmentation cases. Okay, the next paper we did was the classification and management of the postoperative high-riding nipple. This is from Scott Spear in Washington, and also from a recent PRS. So this paper was a classification and treatment algorithm for looking at the high-riding nipple. So what was the general gist of what Scott Spear was saying?
So they were basically giving a classification system. So they were trying to categorise the high-riding nipple, whether it was mild, moderate or severe, and they give basically figures of a percentage of breast tissue that's above the nipple and below the nipple. So basically they're saying if there's 35 to 45% above the nipple, then this is mild. If there's 25 to 34%, then that's moderate, and if there's less than 25% of tissue above the nipple rather than below, then this is actually severe high-riding nipple.
And he also talks about relative versus absolute versus complex.
Yeah, so relative is where you have bottoming out of the breast, and the nipple is actually at a normal distance from the suprasternal notch to the nipple. Absolute is where you actually have a real elevation of the nipple, so there's a shortening of that distance between the sternal notch and the nipple distance. And a complex is basically a combination of both of those.
Yeah. I thought some of his treatments were particularly interesting. He spoke about the double opposing tab flaps, and he used that in 6 cases, mainly in cases which were reconstructive cases where the patient had previously undergone a nipple-sparing mastectomy. Obviously, we're going to do the double opposing tab flap. He wouldn't be able to do that in someone who had any desire to breastfeed or something like that down the track, because you'd be completely severing the nipple from the underlying ductal system. But he also treated some of them with mastopexy, augmentation mastopexy.
And also sometimes raising the inframammary fold.
Yes, yeah, in order to decrease that bottoming out problem. So what was the general reception of this paper?
I think the general perception is that it's a very good paper, especially as a trainee. It really allows you the ability to determine how to look at a breast when you're contemplating what type of correction procedure to carry out, and it really does give it a good classification system and a good way of looking at it. Okay.
All right, the final paper was the Analgesic Efficacy of Lidocaine for suction-assisted lipectomy with Tumescent technique under general anesthesia, a randomized double-masked control trial, and this was from Chile in South America and published in a very recent PRS. I thought this was a very well-designed study where each patient acted as their own control. These were patients who are undergoing liposuction of either the abdomen or back, and they were randomized to receive tumescent solution with or without lidocaine on either side of the body, and then the amount of pain which they had post-operatively at time periods 1, 6, 12, 18 and 24 hours after surgery was assessed. And so what were the results which these researchers found?
Well, the results were good results in terms that it did show a significant difference. They have basically said that significance is where there's a 6% difference between the two, with the lidocaine being the better side. And they've said that they actually stopped after 12 patients because they did find a significant result.
Yeah. However, but then their conclusion based on that was
that they wouldn't do it because it wasn't clinically significant.
Yeah, and that just seemed a bit odd. I don't know why they didn't set the statistical significance that they were looking for to be a number which they thought would be clinically significant.
It certainly seems as though any benefit is significant, I think.
Yeah.
And the risks that they talk about, they didn't actually have any side effects
Yeah.
from giving the lidocaine.
I mean, Lidocaine is generally considered quite a safe drug. Obviously, there are problems at toxic doses. It has a much safer complication profile compared with something like bupivacaine. It was interesting that they didn't try Narrapin, ropivacaine, which certainly many people I'm using for my liposuction and tumescent infiltration in other situations as well. But I thought, actually, aside from their conclusion that you shouldn't use Lidocaine, I thought their actual proven result was that Lidocaine improves analgesia was actually an important thing to show. Okay, do you have anything to add?
Not really.
Okay, fantastic. Okay, so for those of you who were there, I hope you enjoyed it. And for those of you watching now, thank you for listening. Bye.